So today we'll be having the class on IV fluids, which will be taken by Dr. Anand Joshi. He's a consultant in Hinduja Hospital, Mumbai. Can we start, sir?
Yep. Thank you, Nisha. Just a bit of a clarification. I got trained in Hinduja, but I'm currently working in Hyderabad and Sydney as a consultant. Thanks for reminding me of the beautiful days that was in 2006. So at the onset, thank you very much to Indian Society of Critical Care Medicine and the college for giving me this opportunity to be a part of this STEP N program. Very, very important initiative which the college has taken in terms of helping our nurses, especially the critical care nurses, to bring them at par at the international level. This is very important. Today's topic is for me is IV fluids, and this is something which is an inseparable thing from your day-to-day professional life. You will not imagine a single day where you will be juggling with different types of fluids. So, and these fluids have got an important role in not only in saving life, but is also in a treatment of any patient. So, knowing what kind of fluids you are going to use is very, very, very important. We know, I hope we all know that almost 40 to 45% of the body are like solid organs, but 55 to 60% almost is formed of the fluid. Now, this fluid is in a different forms, in a blood form, it is in the intracellular fluid form. So of all the 55 to 60% of the fluid which the body mass is made, we have almost distribution as 1/3 in extracellular fluid and 2/3 in intracellular fluid. So that's the fluid inside the cells. So you can see that only 1/3 of the fluid of whatever we have in the whole body is consist outside the cell, and in that only 20% causes plasma, or what we call it as a blood, without any RBCs. So whatever the blood component is, there is a 20% of the 1/3 of the fluid which you have. Rest of this 80% are the interstitial fluid. So when we are talking about the fluid, it many times we just imagine this person is having low fluids or hypovolemia, so give him some fluids. So you're actually manipulating only 20% of it directly, whereas there is a lot of other fluids in almost 80% in interstitium, and rest of the other 2/3 in an intracellular. So sometimes that these are the things which we need to keep in mind when we are using the type of fluids. Just to interrupt here, I am told that we need to have this session as an interactive session. So please feel free to raise a hand, put in a question, and Dr. Nisha, please feel free to interrupt me if a relevant slide is there and relevant question is asked. Okay. Right. So why is the fluid needed? The obvious answers we have. We need in a body for medium of transport. We need it for a cellular metabolism. It acts as a electrolytes and it other constituent as a solvent. It helps to maintain the body temperature. It also helps in digestion and excretion as a stool. And in the joints, for example, we have them as a lubricant. So these are an overall requirement of the fluid for our body. Now, in a given person or even a given body, there is always a balance. Now, the balance of the water is through the gain and through the losses. So the gain is what the fluid we intake. That's say 1000 to 1500 ml. That should be a standard thing. We do get some fluid from food also, which we eat, and some amount of a very small amount is obtained by metabolism and oxidation of all the food and the nutrients which we get. There are different ways through which we lose the fluid. There is something called as sensible loss and insensible loss. Sensible because we can see, and insensible because it's not visible. The obvious for the sensible losses are we sweat, we pass urine, and the insensible loss are through the skins, through the lungs, and through the feces. Now, ideally, the fluid gain each day should be equal to the fluid loss. Almost a loss of 10%, as low as 10% of the body fluid, that will be almost 8% of the weight loss, is a serious condition. And when you are dehydrated by 20%, that amounts to almost 15% of the weight loss, it becomes very, very, very fatal. Now, what is a minimum output per hour necessary to maintain renal function? So that's the minimum number. What we see is a 30 mils per hour. So that would give us an idea about the hydration. So if somebody is passing a urine of approximately 30 mils in an adult who is around 50 kilos, 30 mil per hour should suffice. Now, we know that broadly what's the use of or why we need the fluids. But when you come to an intensive care or a critical care, the utility of the IV fluids is done as a medicine. Remember, you can't just freely use the fluid the way you want in an intensive care, because there is a very fine balance between the acceptance of the fluid by the body and the rejection. So broadly, the fluids will be utilized in intensive care under these four circumstances. One, resuscitation. So when the patient is crashing, he's hypotensive and or he's in a shock and we are resuscitating, at that point of time, we use the intravenous fluid. Now, when we are using this fluid, we are having a typical clinical goal. We are not randomly using it. So these typical clinical goal will include either the mean arterial pressure, that's more than 65, or a urine output of more than 0.5 mil per kilo, or we give the fluid still, the normalization of the lactate occurs as in septic shock. The superiority of any particular type of fluid, that this is the best fluid and this is the only fluid we should be giving for resuscitation, has not been established. We'll touch this topic a little bit later, but we need to understand that if available or if not available, any fluid can be used for the resuscitation. The second important thing or indication in the intensive care will be the maintenance. Now, many a times we randomly write the maintenance thing, but we need to understand why IV fluid is required for this patient. So when we tell as a maintenance fluid, here we use it for the patients who are not hypotensive or they are not dehydrated or anything. They are hemodynamically stable patient. However, they are not able to maintain the regular fluid intake orally. Now, what are the situations? Like, for example, the patient is nil per oral, or the patient has got dysphagia and or a gastrointestinal obstruction, and there is no gasogastric tube. In this kind of situation, it is imperative to give maintenance IV fluid. Now, Here, the clinical goals are different. Previously, there are the clinical goals of resuscitation, is mean arterial pressure and urine output. Here, the clinical goal is different. Here, the clinical goal is to supplement daily fluid need and not correct the ongoing major loss or electrolyte. So it is just to supplement what a daily requirement of fluid is. That's it. You're not actually correcting any electrolytes or any supplement. The third category is a replacement category. So the replacement fluids are administered in a hemodynamic way. So here the patient is also hemodynamic. However, they are either having vomiting, they are having a diarrhea or high fever, or they've got electrolyte issues. So you're replacing. So this is a replacement of the fluid which is lost. The main purpose of this kind of replacement fluid is to avoid the person going in hypotension or avoid the patient needing resuscitation and maintain the tissue perfusion. The third one will be the supplementing the redistributions. Now, some situations like sepsis or say hypoalbinemic or congestive cardiac failure state, there is a lot of shift of the fluid in the third space. So overall fluid in the body is okay, but the fluid has shifted from this intravascular compartment to intracellular or interstitial compartment. In that case, we will have to provide the fluid so in such a way that the intravascular compartment is maintained. And this is important because all the organ perfusion is maintained by the flow of blood through the intravascular compartment. So whenever there is a depletion of fluid intravascularly and we supplement, it comes under the category of supplementing redistribution. So let's see what are the types of fluids available with us. Now, broadly, again, this has been classified into an open system and a closed system. You won't see nowadays many open system because there has been like quite a shift. There is a historical importance. They were available in the olden days in a big glass bottles. The problem with this kind of system was when you attach it to the IV fluid and IV tube, you have to put a vent, and that would occur either through a puncturing a needle or something like that, so that the fluid will flow. Subsequently, even the plastic bottles were also done, and we have a very common habit of going and pricking these plastic bottle in the needle so that the fluid flows. Now, it has been established that this kind of practice is not good, and the risk of infection goes up exponentially if you randomly start puncturing the bottles. This system is known as open system, and hence, because of the high risk of infection, this open system is now no longer encouraged. There are still many places where they are used, but we have to try to move from open system to the closed system. So the closed system are the new generation collapsible bag, as you can see on the photo where you have these two bags which has got a vent. So these bags collapse as the fluid goes out, and hence they are flexible, they are clear, and hence they should be the preferred one. They also help to maintain the sterility, so chances of infection are less, and the chances of air embolism, which otherwise you would get when you straight away go and prick the whole bottle and push the air, the chances of air embolism is high, but in these cases they are low. There has been many improvement in the manufacturing these bags, and then new generation bags you can hang, and you can allow what is called as universal spike insertion. So there is a spike that is which you can, there is a port where you can insert the spike and the fluid starts flowing. Now, broadly in your intensive care, there are two types of fluids available. So whenever there are fluid bottle or fluid box you take in your hand, classify them in your brain into two types. There will be only two types of fluids. Either they are crystalloids or they are colloids. What's the difference? The crystalloids, you can imagine, they look like, and they are actually just some water. And these water are supplemented with an electrolytes and or sugar like dextrose, which resemble the mineral content of the blood. So they nearby what our blood contains. Those kind of electrolytes like sodium, chloride, potassium are added. One of the property of this crystalloid is that as soon as it enters into the blood vessels, they diffuse out of the blood vessels into the extracellular fluid. Now that can be either interstitial or intracellular. Now this this property of crystalloid sometimes becomes a very disadvantage when you have to maintain the intravascular fluid. Whatever you give, if it is going out of the vessel and it's sitting in the interstitium and again dehydrating your intravascular compartment, is not much of a use. So what happened was, so scientists came up with an idea where they said that with this water and electrolyte, I will add something extra that they call it as a colloid. This colloid will prevent the water and the electrolyte to go out of the vessels quickly, and hence they would maintain the circulation for longer time and the volume expansion becomes fast. So these fluids became to be classified as colloids. So this picture clearly explains the crystalloid and the colloid difference. So if you pour a crystalloids in the intravascular compartment to expand the plasma volume, our blood vessels being a semi-permeable membrane, they go more into the interstitium or extravascular volume, vascular compartment. Whereas in the colloids, which you see on the right of the screen, the leakage is less and the persistence of the fluid inside as a plasma volume is high. And this is the fundamental difference between a crystalloid and colloid, which you should know. Let's look at crystalloids. Now, these crystalloids are further classified into isotonic, hypotonic, and hypertonic. So let us try to understand what does this three terminology mean. Isotonic are those whose osmotic pressure is same on the both inside and outside the cells. So what happens when you give these kind of fluids, because the pressure inside the cell, the pressure exerted by the fluid inside the cell and outside the cells are equal, the cells neither shrink or swell with the fluid movement. But when it comes to hypotonic, these hypotonic has less particles and more of water than the intracellular fluid. So when you give this hypotonic fluid, there is a tendency of the fluid from inside the cell to flow outside. Okay, so this is a property of a hypotonic fluid. And let's see in a hypertonic fluid what happens. They have large amount of particles, and because of that large amount of particles, they have a tendency to draw the water from the cells so that it dehydrates the cells and cause the cellular shrinkage, right? So isotonic the cell has no effect. The inner fluid and outer fluid remains the same. For a hypotonic, the cell, the water from outside goes inside the cell and the cell swells. And in hypertonic, the water from inside the cell come out and shrinks the cell. Now let's take an example of each and how does it get utilized practically. So when you talk about an isotonic solution, for technical reasons, when you say isotonic solution, you look at the osmolality of that fluid, and that osmolality will be somewhere between 250 to 375 milliosmol. The classic example is either 5% dextrose, 0.9% sodium chloride, Ringer's lactates, or plasma light A. When you are using this 5% dextrose in 0.9% saline or a Ringer lactate, these are the fluids when you give will neither enter inside the cell nor they will suck the fluid out of the cell. Hence, they are used as a replacement fluid without disrupting the intracellular interstitium. They are used. Yeah, somebody raised the hand. Yes, Archana Ramakrishnan has asked which IV fluid is best for maintenance. I'm coming to that, dear. I'm coming to that. There is a still. How do I go out?
So click on the close button. In chat box, there is one option. It's visible, sir.
Is visible now? No, but that box has not gone from my thing. Yeah. Okay. Sorry. So the hypotonic solution. Am I audible now?
Yes, sir. You're audible, sir.
So when we talk about a hypotonic solution, we are talking about 2.5% dextrose in water or half normal saline. Now remember, when you are having hypotonic solution, the fluid is going to enter inside the cells. So all the situations where you have intracellular dehydration, like excessive diuretics, cellular dehydration, all these places, we use this kind of solution. However, in certain situation, you should not use this solution, like brain injury or raised ICP, because in these patients, when you use this fluid will go inside the cell, they will swell, and then they are going to further cause a damage. Also, during resuscitation, if you're trying to resuscitate with this fluid, the goal in the resuscitation is to increase the intravascular compartment. But these hypotonic solutions will not remain intravascular. They will immediately go out. So they are not a good solution to use. Coming to the hypertonic solution, here we know that this has a tendency to suck the fluid in. And hence, 5% dextrose in all combinations, all 25% dextrose, 50% dextrose, 3% saline, all these fluids can be used to draw the intracellular fluid. Now, you cannot interchange. There are also specific indications, like dextrose 5% can be used in, say, hypotonic dehydration, as in drowning or in shock. But you cannot use in brain edema because it can be a counterproductive. One point to be to be noted here is that because they are hypertonic, and when you start giving them from the peripheral vein, they will start sucking the fluid from the cells of the walls of the veins or extracellular fluid, and that may cause severe pain and thrombophlebitis. So this is particularly true in 3% saline. And when you're using high dextrose, like 25% dextrose, 50% dextrose, remember that it can also cause hyperglycemia. So let us see in a picture manner. So as I said, in ice, we have three compartments here. We have vascular compartment, blood vessels, we have interstitium, and then we have an intracellular fluid. Normally, there is an equal balance of the fluid which is going on, and in such a way that you have 2/3 of the total body fluid intracellularly, and out of the rest of 1/3, we have 80% in interstitium and 20% in vascular. Now, when you give a sodium chloride to this patient, what happens? So this sodium chloride get sparsely distributed between the intravascular, and some seeps out in interstitium. Nothing much happens in a intracellular compartment. When you use a 5% dextrose, then we know that there is a lot of water and they are hypotonic. So there is a tendency of them to distribute inside the cell and draw the fluid from vessels and interstitium and go and sit into intracellular. So the intracellular fluid may go up and the cells may swell up. When we use the hypertonic glyceride, that is, they are having a lot of particles like sodium chloride, they have a tendency to suck the fluid. And when they are sucking the fluid, they will suck it right from intracellular compartment. So the fluid major movement, as indicated by arrow, will move from intracellular to interstitium, interstitium to the intravascular. So these are the three types of crystalloids you need to keep in mind while using them. Now let's see the colloids. So when these colloids are nothing but crystalloids plus colloid substance. So in any crystalloid, if you add some colloid substance, it becomes a colloid. So essentially, it's a water, electrolytes, and colloid substances. What are these colloid substances which we add? These are the starches like aminopectin extracted from maize or sorghum. Then we have gelatin, and then we have dextran, and then we have a human albumin. Now remember, all the blood and the blood products are colloids. So because they are a natural colloid coming from the body. What are the examples of the colloids? Mannitol, dextran, hetastarch, albumin, either 5%, 25%, hemacil, all of them come under colloids. What do? They increase the volume in the vascular space, they will draw the fluid from intracellular space, and they increase both vascular and interstitial space. They are usually used during the emergency treatment of shock or a treatment of hypotonic dehydration, and they increase the fluid shift from interspace to vascular space. This is when you use these colloids. Now, over the period of the time, colloids have become very, very, very controversial. Some of the colloids like hetastarch and Hesterile, they all have shown that they can cause a lot of kidney problems. So they have shown to cause a renal failure, hence they are absolutely not indicated. Other situations, can you use a mannitol or dextran, all those things. Remember, these, when your intravascular compartment goes up, blows up, then it will create some pressure on your heart, and there again the problem of the circulatory overload, congestive cardiac failure can occur. um, Albumin is a different ball game. That has been a lot of debates, and there have been big studies, especially from Australia, that has said that it is the best for resuscitation. So in many part of the world, it is still a good choice to resuscitate a patient with albumin, especially when your albumin is low. This is the diagram which will help us to understand what the colloid does. So those black dots are the colloids, in which when infused will try to get a lot of fluid drawn from interstitium. However, the amount of fluid drawn from intracellular will be less. Now, this becomes an important comparing point for you to understand between a colloid and a hypertonic crystalloid. So if you see a hypertonic crystalloid, it has drawn the fluid from inside the cell also and the interstitium. But in case of colloid, it is mainly the interstitium. So if when you have a peripheral edema, now the peripheral edema means there is a lot of fluid in interstitium. You have a dependent edema, pedal edema, and all those things because of the low albumin. If you give them colloids, then their edema will come down. Not necessarily that the fluid will be taken or from the cells. So intracellularly, there is a less shift. So this is the advantage of colloids. Which is the best? Now, no single fluid in any of the trials have proven to be the best. The selection should be made depending upon the use for the maintenance or resuscitation or the supplement. If you are confused, like whether I should use these or not, then the best thing is to use isotonic crystalloids, namely 0.9% saline, that we call it as a normal saline, either a plasma light, a ringer lactate, or Hartmann's. If you use these fluids in any of these patients, you will at least cause no harm, if not benefit. When you're using dextrose containing fluids, remember, try to avoid them in a neuro patient, basically brain edema, strokes, or traumatic brain injury. Try to avoid. Also, when you're using a dextrose as IV fluids, remember to check sugar, because it may cause a lot of hyperglycemia related problem. As I mentioned, starch-based colloids like hesteride have shown to cause renal failure, hence it should not be used for resuscitation. Whenever you see HES 6% or HES any other percent, please go back to your doctor and ask, are you sure you want to use this? Because this is not a good fluid. Usually now they are also not keeping it, but sometimes from old stock, if it comes out, and it can cause a problem. Albumin has shown a better outcome in a fluid resuscitation of all the situation except brain injury. So the albumin has shown that when they use it as a resuscitation in a traumatic brain injury, it worsens the outcome. So overall, albumin is safe, but it's very expensive in our country. So we have to use it very judiciously. But when you're using in case of a neuro patient or brain injury patient, it's no. So if you closely see, the safest of all to use everywhere, anywhere, will be the isotonic crystalloid, and all the colloids, whether it's a starch-based or albumin, has lot of limitations. So when you bring a fluid, first classify it whether it's a crystalloid or colloid. If it's a colloid, then go back and look for the indication, because there are more contraindication for colloids and indication. And if it's a crystalloid, then just check whether it's a isotonic, hypotonic, or hypertonic. The simplest way will be, if it's a saline, plasmalite, ringer lactate, Hartmann, they are isotonic. Hypotonic will be the dextrose containing one, and hypertonic will be the 3% saline or 8.4% soda bicarbonate. So this is the overall view of IV fluids. Now I would like to pause here before I go to the next slide to answer any questions if anybody wants. Nisha, I cannot see the questions asked. Anyone has any questions, please ask. Hello, Nisha.
Hello?
Yeah. So any questions from the audience? I'm unable to see any questions.
No, sir, there's no questions.
Janvi had raised the hand. Show the chat preview. Yes, hi. Dr. Abhilash Kavitkar has sent hi. Anything else?
Dr. Nisha, please
Yeah.
tell participant to type their question in the chat box.
So if anyone has any question, please type in the chat box.
Yes, somebody has. Shivraj Kumar.
Please go ahead,
Go ahead.
Shivraj Kumar.
Brilliant question. Does albumin should be avoided in the cirrhosis with the encephalopathy question? Honestly, this is a very trick question, and it is a double-edged sword. However, in cirrhotic encephalopathy, one of the major issue is, I will come to that. The major issue is, because of the hypotonicity of the intravascular volume, low albumin is there. Most of the fluid has gone out inside the brain. There is no direct brain injury. So I will assume that giving an albumin in this case would be beneficial as against any other direct injury to the brain. So the injury to the brain in the cirrhotic is secondary to the low albumin causing seepage of all the fluid outside. But in case of, and of course, there are other mechanisms also, but giving an albumin or albumin Lasix would probably be helpful in getting the fluid shift in these patients. Brilliant question. Shakir, if neuro patients raised ICP on ventilator having hypoglycemia, which fluid can be given? Again, what is going to kill the patient? It's the hypoglycemia that's going to kill the patient. So you have no other choice but to give him dextrose. If you got a central line, you have to give him dextrose enough to cause a increase in the sugars. It is not going to affect the ICP as horrendously as the hypoglycemia is going to kill. So here you have to devil and the deep sea. So you have to choose one thing. What's going to kill him immediately is a hypoglycemia. So you would rather give him some glucose and sugar, and then the raised ICP on the ventilator can be managed with the other methods like head and elevation for say brief period of hyperventilation, or you can use 3% saline later. You can use mannitol, or you can ask the surgeon to do the craniotomy, or put, if there is an external ventricular drain, EVD is there, then you can drain some EVD. So, but here, remember that hypoglycemia is killing the patient. So there's no point in you having a hypoglycemic brain and you're trying to protect the ICP. Completely dextrose containing fluid should be avoided in neuropatient. Brain damage increases ICP. That's true. That's true. But when you have got an hypoglycemia to somebody, I think you are trying to answer Shakir's question. But if your increased ICP is there, but before that, the patient will be dead with hypoglycemia, right? So what are you going to do with the raised ICP when the patient is already dead? What is going to kill the patient immediately is what you need to see. Case of sepsis-induced DIC with shock, how would we manage the fluid? Again, India is a very, very typical where you get the dengue and sepsis and DIC. So the DIC has a lot of capillary leak, and I would rather prefer a colloid, specifically a 4% albumin. If that is not available or if it's very expensive, then I would also always prefer our plain simple isotonic fluid. Patient with acute GE with severe dehydration. Right, now you tell me, Shakir, on this acute gastroenteritis. So there is a fluid shift coming from intracellular to interstitium to your bowel and coming out. So you will need a fluid that is going to go straight into the intracellular compartment, then into the interstitium, and then look for into your intravascular compartment. So probably hypotonic dextrose or isotonic fluid is going to help you, or say dextrose saline, that will be the best. And that's what you give it for the kids also, where there is a some amount of dextrose, there is a some amount of electrolytes, and the fluid gets equally distributed between intracellular and interstitial. So guys, I would, there is a book coming out, manual for manual for nursing people, in case given out by, coming out by ISCCM. I have written a chapter on IV fluids in that. I have detailed most of the IV fluids available, its indication and its caution. So when it comes out, it will be very handy for you guys. Okay. In case of ARDS, now in case of ARDS, it will depend upon why you want to give IV fluids. I would rather keeping on a drier side, and try to keep the lungs dry and won't give any IV fluids. I think we are nearing the time. What I will do is I will quickly go through the last slide, which I want you guys to go through. This is a very good. So these are the NICE guidelines. It is available free of cost. You can type it. They're from UK-based guidelines. It's a very simplistically things. If you are confused about under which situation we should use what. So I told you that in IV fluids in ICU, there are 4 situations. One is the maintenance, 2 is a fluid resuscitation, third is the electrolytes or anything replacement, and fourth is actually when somebody is losing, you have to replace and redistribute. So these guidelines are available on online, and you can download this chart and keep it with you. It has got 4 algorithms. I hope you all are seeing.
Sir, sorry to interrupt you, but slides are not, we can't see any slides.
Can't see it. Why is it not seen? Hang on. Oh, sorry. Uh, yeah, can you see this? Huh?
Yes, sir, it's visible, sir.
Okay.
Make it full screen.
Yeah, can you see?
Yes, sir.
So guys, take a note of this. It's called as NICE guidelines, UK-based guidelines. They come up with fantastic simplistic thing. They give a very practical approach if you're confused when to use what in terms of fluids. They might give you some example for that. But their approach is very good stepwise. First and foremost thing, when you're using the fluid, especially in intensive care, do an assessment along with your airway, breathing, circulation, disability, and exposure. See whether the patient is hypovolumic and or needs any fluid resuscitation. Now, clinically examine the patient, see what are the trend, whether he's improving or he's worsening, whether his hypotension is going down. Then quickly check whether this patient needs any resuscitation or not. When you will need a resuscitation, why it is important? Because here time factor is very important. So when the patient needs a fluid resuscitation, he's either got a low blood pressure, he's tachycardic, he's cold, clammy, he's breathing fast, or his Muse or his News score is more than 5. You are looking at using the fluid for fluid resuscitation. So when you're doing it, while the doctors are identifying the cause and what is the deficit and respond, you can take a 500 mils of crystalloid. Now, whether that might be a plasma light or a saline or a Hartmann's or the Ringer lactate, and connect it to the IV cannula and start giving the IV crystalloids if the patient is dehydrated or hypovolumic or in a shock. Make sure that you are not giving it in a patient who is in a pulmonary edema or giving in a patient who is in a congestive heart failure. Now, once you have given this 500 mils, you have to reassess it. You don't have to eternally give. Every time you give any fluids, once that bag is over, reassess. Does it still require resuscitation? Yes, then give further more fluids and contact the doctor and ask them to review the patient. If he doesn't require, that means the patient shock is resolved. Now, always remember, with every utilization or the goal, you should have a particular goal. And once that goal is achieved, you have to go back, assess the patient's history, look whether he further requires any fluids, whether further he requires any electrolyte. Now, if he requires further maintenance of the fluids or electrolytes, then make sure that his nutrition and fluids are needed. In which case, you have to see whether the patient is able to take orally or whether he's eating or drinking adequately. If the patient has got a complex electrolyte replacement issue, like the potassium is very low or magnesium is very low or sodium is very high or low, any of those things are there, then you are looking at replacement, that is algorithm 4, replacement and a redistribution. So depending upon what electrolytes he has got, or if the patient has got NG tube on free drain, whether he's got a stoma which is pouring out a lot of fluid, whether he's got a short bowel syndrome, whether he's got 104, 105 temperature and he's pouring out, whether he's got a pancreatitis, whether he's got a post-surgical drain which is giving a lot of drain, all those things are abnormal fluid loss and electrolyte. So even though patient looks okay, but you can predict that this guy is going to require. In this case, what you should be careful is try to be little bit mathematical. How much ever is coming out, say from NG or GI vomiting, or it's a diarrhea or a colostomy loss, try to approximately calculate how much it is lost and try to replace it. And this is what the algorithm 4 tells us. Now, when all these things are not there and you're just looking at giving a routine maintenance, then be careful. Just give basic 25 to 30 mil per kilo, say for a 50 kilo. And remember, 25 per mil per kilo per day, that is in a 24-hour period. So if I have to make it very simple, what I would say is give 1 to 1.5 mil per kilo. So for a 50 kilo man, either 50 mil per hour or 75 mil per hour, or 60 kilo man, 80 mils an hour of fluid is a reasonable way to start. And once that IV fluid is going, always reassess the patient whether he requires or not. If he's taking adequately orally, there is no loss, then probably you should stop the IV fluids. So I think this chart is very important and good, along with the other manual which you will be soon be getting from ISCCM. In that, very in detail, the things are written, what we spoke just now, and these two things combined will be very helpful. So that's all from my side, and I'm open to the question.
Any further questions? So if there is no questions, then we conclude the session. Thank you, sir, very much. It was a very informative class.
Thank you. But you're happy for me to log out?
Thank you, sir.
There's one more question here.
Oh, there is one more question. Okay, let's take that question. Any standard criteria for fluid assessment? Yes. So the standard criteria is the same criteria you use for routine examination of the patient. You go with the clinical examination, you ask the patient whether he's thirsty or not. If the patient is not able to communicate, do the clinical examination. Cold, clammy extremities, severely dehydrated, not in a congestive cardiac failure, skin turgor is gone. He says that my urine is very high colored or the low urine output. All these criteria will direct towards your dehydration. Then you look at the heart rate and blood pressure. So heart rate will be tachycardia, blood pressure will be low, hypovolumic will be there. And on when you look into the blood investigations, you will have a high urea as compared to high creatinine. So he may be having a renal failure, his urine output will be low, and his lactate might be high. So all these things can be used to assess for the fluids. One of the dynamic thing which someone also put in was you can use what we call as a straight leg raising test. So if the patient is ventilated, hypovol, and you are not sure whether he'll be benefited by using benefited by fluid or not, just go raise their leg at 45 degree, wait for 30 seconds, and look if he's well monitored. Then look for the rise in the blood pressure. If his blood pressure rises by 20 millimeters of mercury, that means he's a fluid responsive. So that is another way to do it. Yes, there are more complex ways. Now ultrasound is used to look for the IVC collapsibility. Good old days, there used to be JVP. There used to be a CVP. It has its own drawback. There were pulmonary artery catheters. There are different other invasive way, but all of them is to say whether the fluid is adequate or not, which is a very, very difficult question to answer. Good question. So if somebody has lost 500 mils, now remember, blood is a colloid, right? Now, they say that the distribution of the crystalloid is 1:3 in compared to colloid. So for a 500 ml of blood, you are actually looking at somewhere around 1500 mils of crystalloid to be given, particularly isotonic crystalloid, to say that, okay, that is going to help in sustaining its intravascular compartment, because almost 2/3 will go away, 1/3 will stay in case of isotonic. If you're using hypotonic, then most of them will go away and you will be using ridiculous amount of fluid just to compensate for 500 mils. In case of hypertonic, which may or may not be a best idea for a 500 mils of blood loss, you can give almost similar amount, and definitely for an albumin, you can have that similar amount of 500 mils of albumin to replace it, 20% albumin rather.
Any more questions?
I just want to request you that please on your camera. Dr. Nisha and Dr. Anand Joshi both.
Yeah.
Yes.
Anyone?
There is no question, so we will conclude the session, sir.
Yeah. Thank you. Thank you all. Thank you, ISCCM. Thank you, Nisha, for having
Thank you,
me on this.
sir.
And thank you all the participants. All the best. And yeah, you can look forward for that book which is coming up by ISCCM, and also go and see these nice guidelines. Always remember, whatever the things which you use for patient, you should be well aware of those. Thank you.
Thank you, sir.